Yes, I'm Mark Collier. I'm a nurse consultant and associate lecturer based in Lincolnshire, which isn't a million miles off the beaten track, I promise you, to the right of the A1. But no, it's got a lot of diverse issues within the patient profile because it's very rural, as well as, you still have lots of acute injuries. How long have I been in tissue viability? Well, my background initially was orthopaedics, and as a naive charge nurse on my first charge nurse's post in charge of an orthopaedic ward, I said, nobody's going to develop a pressure ulcer in my ward. Did they? Absolutely. Which stimulated my early research on how do these things happen. As a result of that, we set up the Wound Care Society. In 1988, I am still only 25, just to reassure you. Maria won't believe that, or Jay, but no, no, seriously. And that's now become the Wound Care Alliance, which is great. And I'm currently the chair of the Leg Ulcer Forum, and I want to reassure people the Leg Ulcer Forum and the Leg Club are not in opposition. They work together, and I would just hate it if anybody thinks there's a tension between the two. There isn't, and I'm delighted that Ellie invited me again to speak at this group. Who's the most important educator in this room? I could give you a clue. It's not me. It's you, because I'm very fortunate that I always get a chance to speak to people who want to be here. That is correct, isn't it? He says with fingers crossed. No, you've got to go back to the ranch and convince your colleagues that the things you heard today might be of use in their clinical setting. So, keep it, yes, I know a little bit about tissue viability, but I want this to be interactive because I would argue I still learn from everybody every day. Because tissue viability changes all the time. It's a massive subject. Nobody knows everything. We all have interests, and that's absolutely fine. It should be focused, but we've also still got a lot to learn. So we're just waiting for the presentation here, but if it doesn't happen, I'll just start anyway without it. I apologise about this. Just very briefly then, how many people work in the community? Acute? Another? Anybody work for a company? Don't put your hand.
I work for myself, so I'm a foot health practitioner and private practice. So
that's fine.
I'm here just
yeah, no, don't be shy. Don't be shy. That's fine. That's okay.
I actually don't work for a company.
Do you not now?
No, I don't know.
Apologies. Sorry.
I'm a clinical consultant for the Leg Club now.
Excellent.
So I'll go around supporting the Leg Clubs.
Grand. No, thank you for that. Thank you for the clarification, because you know how you know people, but of course when you only meet the tissue viability world get together most at conferences. There's so many of us that invariably I always get a bit I get disappointed that really all we ever do with people and that anybody you don't know is as important as people you do know, just to reassure you. But all you ever do is have a chance to say, hi, we must catch up, we'll see you over coffee. But that never happens because we're all doing 101 things at different times. So I won't make any apology. Anyway, I want this bit to be interactive in the first sense, if we can. So I'll ask you to discuss, just the person next door or the three of you at the back. I think we're going to just get started. Apologies about this. If it actually comes up, then that's great. Otherwise, I'll use my handout as a prompt. I think I know what I said. No. As I say, there's more in the handout than we're going to get through. It's for your revision, and as you would expect, hopefully there's some good evidence, i.e. in references, for you to follow up in your own time. So, first of all, how many of you would say you actually work in an organisation? Sorry, I'll start again so you can chop that bit out. Okay, it's a real pleasure to be involved in this session. Really great to meet you all, and I feel very privileged in a sense to have that opportunity. So, how many of you now would say in your clinical practice that you truly work in a collaborative setting? Yeah, okay, that's great. Don't be shy, and it doesn't matter if you say yes or no. It's just to get a feel. So when you say collaborative, how is it collaborative?
So we've got close links. I'm a lower limb specialist, so I've got close links with the community teams that I work with, and then into the acute with vascular and podiatry teams. We use industry quite a lot for help with compression garments and that sort of thing in clinical advice. So yeah, I think we work collaboratively.
Great, no, that's fine. That's a really good example. So anybody else say they work collaboratively on a daily basis?
With some teams and not so much with others.
You have to excuse.
With some teams, but not so much with others. Still.
Because we, the multidisciplinary team approach has been well known, hasn't it, and well advertised. But sometimes, in my experience, I wouldn't say we play lip service to it, but it doesn't work as well as we would like it to. And why is that? It's because of what's involved in the individual, isn't it? So in that individual person within the multidisciplinary team. So some doctors are great, some think they don't need the nurses, as an example. So what I've got now, and it's on this first slide anyway, it's going to come up. I'd like you to just think of what does working collaboratively mean to you, and how would you describe working collaboration to somebody in your organisation who doesn't really work in a collaborative format now. So if you could just talk to in pairs about that for a few minutes. We won't go for too long. There you go. So what does working collaborative work? And what I'm going to do is try and fill this flip chart with your feedback, okay? So over to you. Okay, only just simply because of time, we'll round this up, but what sort of themes were you talking about if you were to try and explain it to a colleague? What sort of highlights would you identify on this flip chart that would suggest how you work collaboratively?
Listen.
Sorry, I thought you said.
Listen. Yeah, listening.
So listening, okay. So listening, and would that be like in respect of each other's views? Am I okay to add that?
Answer the client, patient.
Respecting others' views. Okay. You might differ with them, but you can still respect them and discuss them, can't you? So, any other words that?
Communicating appropriately.
Okay. So, who's the communication between?
Different departments or professionals, basically.
Yeah. So, professionals. So, let's just put that as staff. Anybody else?
We talked about sort of recognising and respecting one another's roles and the part we have to play,
Yeah.
including members, patients.
Absolutely. So staff, patients, because they are quite an important member of the team, aren't they? Really, it is them that we're trying to benefit at the end of the day. And anybody else? Our commercial partners. It's gone very quiet. Okay, so I'm going to put companies just for how many of you now would say today would say you work collaborative with the commercial partners, the people who supply products to your areas? Just very briefly put your hand up. So we've got less than 50%, which is interesting. But they are really important, aren't they? As much as anything else, they give you access to education. Now, of course, it should be education that's benefiting you, not just education they want to give you. That's a different issue, isn't it? But that, if you have those conversations before, you can tailor-made and improve that collaboration, can't you? And one of the examples I'll give you at the end, and it is only an example, is how we did that, but we'll come back to that, okay? Your involvement is really important. So that's interesting that less than 50% say they truly have a collaborative role.
I'm interested to know the 50% that don't. what's blocking it.
Is it,
That's
just for brevity of time, is there any one reason why you think that doesn't happen? Is it because somebody else doesn't give you access? You haven't got time?
I'm not clinical, so.
She's not clinical.
Yeah, right.
Don't be shy.
Money.
Anybody? Jay? Or
Money.
money? Okay. What, you couldn't access money, or?
I don't earn enough to get some of the kit that I need that would like do my job better.
Right, so you can't afford the equipment that might help improve your patient care. And that's fair. That's a very good, so it's a resource issue in your sense, isn't it? It happens to be financial, but it's still a resource issue. Are you allowed to speak to companies?
It has to go through a more senior person than myself. I could probably suggest addressing, but it just boils down to money.
Right. So another resource. Are you allowed to have any input as to what dressings you use?
I could suggest,
Or is it just the senior person?
It would be the senior person who, if I suggested to her, could we put XYZ on someone's leg?
Yeah.
Because when I was working in the community, I was a pool nurse, and I would have had to ask the sister. She then goes in and sees what dressing could be altered if need be.
Okay. Would you be allowed to say, that's really good, but have you heard of another dressing?
I could say that, yes, but it's still up to hers, because I was not working I was a pool nurse, so I went here, there, everywhere.
Yeah.
And they don't really take my opinion.
So you didn't really, your view wasn't really valued, in other words. And that's a really important thing, is for a teamwork to work efficiently, we have to have shared values, don't we? We all need, and the companies do have the same value as us. They come from a slightly different perspective, but what do they want to do? They don't want their product to make the wounds worse, they want it to improve wound healing. Otherwise it's not beneficial to them or us, and we use a product, never works, what we're going to do? Not ask them to come back again. So it's really important that both sides have those shared values. So okay. Anything else you desperately think I should put on this? Thank you very much for that. That was really important, because that is a really good and you won't be the only person. I believe in teamwork involving everybody in my team, I promise you. But that doesn't always happen. We have to live in the real world. So today is all about changing practice. When you get back to practice, if you're not in a good, in an environment that doesn't necessarily represent all of this, we can change it, but you can change it by stimulating discussion about the benefits of it, which hopefully you'll have in the handout at the end of the sessions. Okay, so moving on then. What's the rationale? Well, the rationale, and a lot of this, I'm not going to go through this line by line, it's just highlights because we haven't got time. And I always put more on the slides because I want this to be a learning education after the session. You'll have time to read them and the handouts, and there are lots of references, so for you to follow up. But, the NHS has always aspired to offering personalised care, i.e. care tailored to that individual, not one size fits all. Does that really happen? The answer is no, it doesn't. Even formularies can stop that happening. The formulary that we developed, I was a firm believer that it had to have choice. Because to be fair, just as an example, hydrocolloids work very similar. It doesn't matter who makes them, but what might be different is the adhesive. Now, if I don't only have one hydrocolloid on the formulary and somebody reacted to it, I've gone through a whole assessment process that says a hydrocolloid is the right dressing for this patient at this time. If they react to it and I've got no other alternative, where do I go to another product, which isn't necessarily the ideal from an assessment point of view for that product at the time. So if I have a second hydrocolloid, I can try that, but obviously with, increased supervision to make sure that it is the adhesive, not the base material that they're reacting to. Do you see what we're saying? So they need to be expanded, not shrink down to you can only have one product in each classification, in my opinion. So there's a lot of that. The Health Act in 2022 was devised to build a more joined up collaborative health and care system. I think we've agreed there's still some way to go. An example of that in my own clinical area in Lincolnshire, I couldn't say that's actually truly happening. One of the things that has been a barrier to collaborative working is GPs becoming fund holders. Now, not all of them, some are really excellent GPs, but unfortunately I've come across examples where some GPs in Lincolnshire will only do things that attract money. So they'll do every well woman clinic, they'll do every vaccination because they get paid for that. It's a government target, attracts money. Very quickly, as an example, as why that has a detrimental effect, is that a patient who from Lincolnshire was up in Hull, had a road traffic accident, beautifully treated in Hull by the vascular surgeons and the orthopods, but had quite a nasty lower limb fracture. Compound, all sorted out. When she was discharged back to Lincolnshire, a letter was written to the GP from the team in Hull saying, could you get vascular studies on this lady ASAP just to confirm her vascular status is all intact? And she has a minor wound, could you organise regular wound care and see her? 3 years later, I get asked to go and see the patient because she has a, quote, non-healing wound. I go along to speak to this young lady in her home, obviously with other clinical staff to be fair, and somebody who was coordinating the care at the time. And I simply, I sort of said, how have they treated the wound up to now? And she said, a healthcare support worker comes along every 4 days and puts a new piece, takes one piece of melamine off and puts another piece on. Started ringing alarm bells. I said, that's interesting. What do they clean it with in between? Oh, she doesn't clean it. I said, does she have gloves? No. I simply, did a Doppler there and then, confirmed that her vascular status was okay, obviously got her referred to the vascular studies to confirm that that was okay, and started with simple interactive dressings with an appropriate wound cleansing solution. Doesn't matter what the names are, that's irrelevant. What a surprise, a month or so later, her wound had healed. This lady had had 3 years of agony and a non-healing wound and massively affected her quality of life. So I think you can see we still have a way to go, but we should all be striving in that direction.
10-minute warning.
Sorry?
10-minute warning.
A 10-minute warning. He's learned from the previous session. Anyway, so collaborative working does involve cooperation in all parties, doesn't it? And that does include the companies. We shouldn't see companies as the enemy. They're absolutely crucial, both from an educational point of view, but they have evidence to the research we wouldn't have. And, they know me quite well, I'm pleased to say. So they know if I ask for evidence, I'll want laboratory evidence, because that is important when we're choosing products for a formulary. But I wouldn't expect a ward nurse to want, or in the community to want all the laboratory evidence, but they still want evidence to say it's clinically relevant, it works on that wound type, don't they? So we all need evidence. And working with people, we do build up that mutual trust. I still know people who don't trust companies. Some trusts won't let them anywhere near the staff, which is a really retrograde step. Unless you get a chance to talk, you can't improve. So it's all about us changing. It's all about changing practice and changing thoughts about individuals and groups. So this is just one very quick example, and I apologise. There are some more interactive things for you to do, but that's probably going to be after the session now, to take back to the ranch. Well, we developed an outline protocol for collaborative working. So we had a proper protocol that was all approved internally, and all of the companies were invited when we were developing our formulary to come along and present the evidence to me about all the products that they felt were relevant to our clinical profile group, which they did. Obviously the Trust had full knowledge of this and gave us permission to go down this route. I was very lucky because I had a supportive procurement team who I said, look, I'm really not interested, and I generally never ask what the cost of a product is. I ask, what does it do? I choose because it's clinically relevant. I let the procurement team then discuss with our commercial partners what's the best price they can get for. That's their job, not mine. So we did it that way. After we'd got that initial conversation over and everybody was happy with the protocol, then I'd have a formal meeting with the individual companies at different times saying, okay, which product do you think is best for our patient profile? And actually, where would you like us to evaluate it? Rather than me putting it in an inappropriate clinical area, we worked on their suggestion. It might slightly vary for a whole various reasons, but we would go through that, and I'd identify the clinical area that product was going to be evaluated on. Obviously, we wanted to include the clinical staff because they were the ones that were going to use the products. Really important. Their feedback was crucial to the whole process. We then took place between me and the Trust TV team, and of course my team were very much involved, and discussions took place with senior nursing staff, so they were involved as well. Further to the evaluation process, the evaluation was undertaken. At the end, all drafts of the material were sent to the companies who had been involved. They weren't able to change anything I'd written, except if there was something factually incorrect about their product, which I think is fair. Because, I might have misinterpreted what somebody said, I must have misread what they had said. Fortunately, that didn't happen, but it's an inclusive. It should be an inclusive process if it's going to be collaborative. So we went through that process, and we got, addressed and that. In this case, it was all the same process was operated in the complex wound clinic I worked, and we would ensure that patients actually understood what dressing that we were using, how it worked, and what compression system, how that worked. We would also encourage them to know a little bit about the healing process. Now, of course, I'd talk to them in slightly different ways than I would talk to you but they knew it was 3 phases. They knew various things that improved the chance of that and how long those phases should last. So it was really important there. And as a result, we developed a joint formulary with the community staff. Again, really important, joined up, because improved outcomes in the community, in the hospital. What did it mean? The patient was being discharged with a healed wound? You bet your life it didn't. They were going out well before the wound had actually healed, so we wanted continuation in the community. Absolutely pointless starting off with us with product A and they go in with product B if it's a very different product, or it doesn't have the same evidence base. So it was really important that we did that, and then we got various bodies to improve. So what, in my opinion, are the benefits of us all working collaboratively? Well, here, improved sharing of evidence-based practice. I'm sure you'd agree with that, yes? Is that beneficial to us all? I hope so. Improved decision making. It meant we were more focused. As I say, I live, breathe, and almost sleep when I do sleep. Never sleep the first night in any hotel. Well, that's another issue. But seriously, improved decision making, it means that people were making more informed decisions. I won't say better or worse, just more informed decisions. Increased innovation, people were more interested in actually evaluating other things, and much better for the patient because they truly understood what we were asking them to do when they went home. Patient is one of the most important people in the whole equation, isn't it? Because we all want to improve their lot. Qualitative, collaborative teamwork leads to reduced length of stay. That was great. So, as I've indicated already, patients were being discharged earlier, appropriately so. Did that mean the hospital bed was empty for a very long? You bet, it wasn't. All it meant was utilisation went up, which was obviously good from a management point of view, but that's the referee saying we've got 5 minutes. And then increased access to additional data, which of course meant, obviously I would be seeing company representatives over the whole year at different times, and when they brought me the information I would make sure it was, my team knew about it, but it was disseminated to the wards. But equally it meant that the ward staff had access to education, because when the evaluation wards or clinical settings were identified, we identified which was the most appropriate product for them to evaluate, and we would get the companies to go to that ward to do the education. Not me. It was important that they did it, because the 60 people in my team, we could have all said a hydrocolloid works slightly differently. None of it would be wrong, just a different way of expressing. So we always got the companies involved there. So that benefited everybody. Collaboration among healthcare improved patient education and patient engagement. They were really stimulated, which was great. Summary of benefits. Obviously, what was important is we live in a multicultural society now, don't we? Which is I think it's a real benefit to us all. And so we had to make sure that the information we were giving them, the individuals understood. And it was in a format that was beneficial to their understanding. Improved clinical outcomes we could prove regularly, and the collaborative approach led to patient improvements, and that's an article that you won't be surprised is in your reference list if you want to review it. Access to additional quantitative and qualitative data, because both are important. It's not one or the other, you need both. And opportunities for agreed appropriate education. So, the companies had more opportunities to give us the right information to a wider audience. So beneficial all round. So in conclusion, it created opportunities for learning. It enabled access to people who would not normally be reached in order for the service to have an increased body of people. Having potential to develop lifelong relationships, and I'm pleased to say I've known a lot of people from companies for a lot of years, which is great. And we don't look as you're from a company, we're all there to promote wound care. Gaining knowledge, being made aware of increasing productivity, sharing the resultant benefits, spreading the message. Obviously we do need to be cost sharing and cost effectiveness, but that's obviously, as I say, that was for the procurement team to sort out, and we were able to demonstrate that over time. Increasing access to funding bodies and having the opportunity to share knowledge, all were benefits. So what I want you to do, if we'd had slightly longer, I would have asked you to do this at the end of the session, and we would have had a little bit more time to discuss the actual example in a bit more detail. But take these questions back to the ranch, go back to your clinical settings and use these, A, for yourself, but also just to stimulate that conversation between your colleagues. Because as I said right at the very beginning, you're the most important educators. You can change practice. And you can change practice, obviously, if you work with a team, much more easily than you can if you work as an individual. But it's still not impossible. When you get the opportunity, ask the question and just stimulate that conversation to try and promote a much more collaborative or improve the excellent collaboration that you already have. Because I'm the first to say I'm learning from people in wound care every day. I've been around a little while. Do I know everything? You bet your life I don't, because there's so much more to learn. So because you haven't had much of a chance to talk to me during this session, trip me up as we go round over dinner. Feel free to talk to me about wound care. I'm quite happy about that. But no, I'd love to hear your experiences. So I hope that's been useful and a simple introduction to the subject matter. Because evaluations are really important both for the Leg Club and myself, please do use the QR code at some point during the day. If you liked what I say, my name is Mark. If you didn't, it's John. But see, genuinely, thank you very much for your attention and involvement at the beginning. And as I say, enjoy the rest of today, and we'll see you as we go round. All the best. Thank you.